The attendance will be shared at 3:30. You will have 1 hour to complete it. Kindly complete your master attendance as soon as possible, as soon as it's available. Okay. So our first speaker today is Professor Dr. Golam Zakeria. Dr. Zakeria is currently Professor of Engineering at University of Applied Sciences in Cologne University, Germany. He is also the founder and chairman of South Asia Center for Medical Physics and has more than 40 years of clinical experience with more than 115 publications. Dr. Zakeria, it's a pleasure to have you. Please, the floor is all yours.
Thank you very much for introducing me to this audience. This is a very nice platform. I'm very happy to be a part of this session, to this workshop. And it is actually dedicated to Professor Dr. Faiz Khan. Actually, it is unfortunately, I did not meet him anywhere, but I know he's a very great faces all over the world. Especially his book is used all the English-speaking countries, and the student was very happy. I have a talk yesterday with some medical physics and student. They are also very happy to have this book. It is a very, very nice book. I have once this book in hand in a developed country. I visited a conference there, but I live in Germany. So in Germany, they use most of the books in German language, but when anybody want, they can also use such books as a reference book. And I know it is a very good, you have organized here different chapter, but I have no direct contact, so I could not give a lecture in any chapter in spite of asking from the organizer, especially from Mr. Asad Yusuf. Still, I have prepared a lecture here with advanced treatment techniques. I will try to give some informations about the treatment planning for external beam, which is very, very important. Most of you are doing treatment planning for external beam. Of course, we have brachytherapy, and this is also a very good option, especially for developing country, because it is very cheap and we can use it very easily. But it is a sometimes invasive procedures, though many medical doctors do not use it. But I hope that the brachytherapy is also coming in all over the world. So I start my lecture here, and I have 45 minutes time. I think I will cover, and after that we can have a discussion, and when anybody also give his ideas on, so it is a discussion. Just it is not that two way that you ask question and I give the answer. Anybody can also take part in the discussion. I hope it can be a very interesting discussion. Thank you once again for inviting me to give this chance. First of all, I also give my best greetings to Professor Dr. Faiz Khan, and of course here the organizers, especially the Asad Yusuf and his team. And of course, I also my best wishes to all Pakistani physicists and my friends in Pakistan, and of course all over the world. Thank you. So I was asked to put a questions, and I have put a question here. Compare volumetric intensity modulated therapy. This is very popular all over the world. People are doing everywhere, but there is still some other modalities. You know, the classical or conventional intensity modulated radiotherapy, the IMRT, it started and it is improved so that the VMAT is now popular. And of course, in some hospital, you have the helical tomography is a AST. Many German hospitals also use it, and we can discuss later actually the difference between these three modalities. All are modulated radiotherapy. This is first of all, I have taken these slides from some vendors, and you see here the three modalities is the surgery, chemotherapy, and radiotherapy. This is okay, but we are the medical physics, so our tax is also radiotherapy. Yeah, some people are doing also some project work. The effects of all the three therapies, they are also medical phases. When I apply radiotherapy and in also chemotherapy, what is actually the interaction? Can I reduce the dose? And like such types of problem also have dealt many people. You see here the external beam therapy, yeah, the conventional 2D, 3D. 2D is also used today, some binary treatment, yeah, even in Germany. So it is not the old fashion. Yeah, it is also used for binary tumor. And then 3D and IMRT, VMAT, it is actually very popular. And I will explain, started with 3D, yeah, it is direct planning. And when the people, especially medical physicists know how they modulate with the computer their plan. So it is easy for them to use later to understand the inverse plan, yes, in MRT and VMAT. And stereotactic radiotherapy is also very popular, and many hospitals is doing this. And of course, the brachytherapy you see here, high dose rate and pulse dose rate and low dose rate seats. And what I also write here, the electronic brachytherapy, it is also very popular. Yeah. In my earlier hospital, they have electronic brachytherapy in the standpoint of radiation protection. You do not need a huge radiation protection, so you can use it in the operative theater. On the other things here, you know, many therapies is possible, and this can be used according to the needs of the patient when we want. Here, somebody is also writing somebody is writing, I have seen some fatal consequences, and you see, to kill the cancer cell, it is our challenge. It is the challenge of medical physicists that we want to apply optimal dose at the target and minimal dose in the surrounding tissue, especially for the critical organ. And this is the optimization, this is the challenge, and we are doing this. And there is a methods, and there is tables, and we try to maintain these things. Here you see the dose should be accurate. When you have 5% low, may result a clinical detectable reduction of tumor control. So when it's less dose, it is also not good for radiotherapy. Radiodiagnostic is okay, you have a high limitation, and after that you have, but in radiotherapy there is two limitation. Yeah, this should not give less dose, should not give more dose. Yeah, this is actually a optimal range that we should do. And you see normal tissue when 5% high dose, then is also a complication in normal tissue. This should be also taken consideration. May involve the deviation from prescribed dose. The medical doctor gives a certain type of tumor, and may involve severe and fatal consequence. The IEA, you know, everybody, the IEA basic safety standard, this red book, SS 115, require prompt investigation by licenses in the event of an accidental medical exposure. It is actually medical physicist, you know, we should also have a clear idea how to minimize the possible risks. Yeah, there should be your hospital, you should have a measure so that when possible risks come, how can you handle it? This is also obligatory in Germany, and all countries, we should have prepared for that. Here you see the professional involved in the treatment planning process. It is given by IA. Everybody can have the syllabus book and you can read it. And I will go here two things for the medical physicist: dose calculation and optimization. Yeah, this is actually real tax of us. yeah, it is involved in commissioning for the planners and quality control. Yeah, acceptance testing, know this, it is also a tax of medical fees. After that, the commissioning, it is solely your tax. And then naturally the quality assurance program. This should be done the whole year. And this is the second time medical fees is monitor units and dose calculation. This is, I think, is possible. You have a second verify system. When there is a verify system, then it is very nice. After the main treatment planning, you verify whether the treatment planning okay. Independent second control. It can be done according to the experience of many older faces. They can do with hand handling, but there is a many software you can have also in internet, and take this software and you can control it. I suggest please always a second verification and then apply to the patient your treatment plan. Here is a radiotherapy chain. You see as a huge, it is started for clinical examination up to the aftercare evolution. And what is important here, I do not go to details. You see it is actually therapeutic decision, 3D imaging, localization, treatment planning, simulation, dosimetry verification, patient positioning, and radiotherapy, of course, and aftercare. And what is important for us, you see, imaging is the central to each step in the process. So in the earlier time, we are always therapy, radiotherapy, but radiotherapy now is imaging, yeah, is a very important. So we should have a clear idea how we use the imaging and what can we improve the therapy through the imaging process. I have given here a very simple imaging and of course the therapy planning and the treatment, the three most important main process. Here, you know, everybody doing every day that is started from fixation and then CT imaging and then treatment planning and then of course the control of positioning and the treatment. What is important in this slide, you can see the radiotherapy is a unique among the cancer treatment modalities because it can be modulated in space and in the time. That means you have the possibility to modulate it not only in the space but also in the time. Yeah, and I will show you my coming slides how you will do this. Yeah, and this is actually radiotherapy. This is a unique. Radiotherapy is most developed branch of medicine. Yes, because we can apply here technology, physics, and mathematics very well. So we can calculate a millimeter way, a millimeter exact. Yeah, that's why the quality control is important for us. Here, the positioning, yeah, I will not criticize the physicists, but most of the physicists I met elsewhere do not care about the positioning. Yeah, they think it is the work of radiation technologies. Even they did not know how many immobilized devices in his hospital. I just ask you, it is the first condition to medical physics, please work with the technician very well, try to understand this positioning, because without the right positioning and immobilization, all the next step is not so fruitful. So we should know the positioning procedures, and it is started from the CT up to the treatment. Yeah, so on here I have written fixation aids and marker from the skin permits reproducibility. This is this, and this reproducibility is, and when the change during the whole treatment, even what should you measure? This is actually important of the setting by means of stationary laser coordinated system. So I go to the next one. This is actually the imaging fusion. Imaging, you know, we need the most important is CT. Yeah, as a physicist, you know, without CT, without the three-dimensional CT, we could not do our treatment planning. Earlier time with Röntgen Röntgen photos. The medical doctor also do some treatment. Yeah. But what is this? This treatment, I am one of the old generation. We have done without CT, but not so exact treatment plan like this. At the time, we have an AP and LA, lateral and anterior posterior Röntgen photos, and with these photos, the medical doctor prescribed some things, and we have done some APPA treatment, yeah, at this classical time. And at the time, the treatment, we can cure the patient, but the surrounding effect too high. Even the cure rate was not so good. So we are very thankful that the CT is our daily tools now, and we can detect the tumor very well, and we can also plan very well. And this is another modalities. You see the MRT, PET, SPECT, and everything. And we can also use such types. A medical doctor can use this, and they take the advantage of other modalities to correct his CT contour. This is possible because sometimes some tumor in CT you cannot visualize this one very well. So we need the PET maybe, and then we transfer the PET possibilities to the CT, and then you have a right tumor. And what you see, this is a hybrid machine. Most of the hospital, you have the hybrid machine. Hybrid machine actually good for patient, but it is also sometimes disadvantage for us, because you have maybe a technician who has only the knowledge in radio diagnostic, radio X-ray department, but in PET is nuclear. So is their qualification is enough for both machines? So sometimes it's very difficult. Should we send them to qualify also nuclear medicine? So it is difficult for us to have a permission whether our person have the both qualification and both certificates. And this is also not easy. So it is the new challenge for the medical fields is to take permission from the authority when the hybrid machine with the different modalities in the same department. Yeah, we have also other situation with nuclear medicine than radiodiagnostic. Here is not only the exposure, but you have also here contamination. This should all should be considered in the daily life. This is actually important for us. So I go to my next slides. It is a treatment planning. We are very happy that we have all over the world, we have the ICRO reports. Some countries, even the Germany, they have their own protocol, but based on the international ICRO 50. And before that, we did not know, every hospital different, every country different. Now we have an equalization so that we orientate this one. You know, the supplement also 62, the both are very nice. You can also download from the internet, and you can use both of them very nice. And I have written here different things. You know, it is started from GTV to PTV, and PTV for medical phase is very important. When we have the PTV, we can also plan. And even in their organoprics, they have a PRV. That means here we have also some margin, and medical doctor do. And even my old hospital, we have contouring the patient, except all the organoprics we have drawn at the time when medical doctors only do the PTV. And I have written is very important things. This is CTV actually, yeah. The medical physicist and we are trying to do a very good motion management, but actually main problem is at CTV. Should we draw the CTV very well? This is actually the question, yeah. So I think with the era of artificial intelligence, we can do a CTV is exactly, and we can improve the patient treatment. So the CTV is a challenge to do the right CTV. Here I have given a picture from the internet. You can see which modality is used for which volume. Here, this is I have taken from my colleagues, Professor Hartmann is a good friend of me. He visited also many times in our continent. And this is, you see, Here is given the situation in Germany. I think it is also internationally. You see here, you can see the localized tumor, the metastatic tumor, and you can see the operation, radiotherapy, and chemotherapy. What is important for us, you see the 18% failure of local control. Yeah, and here palliative treatment, we have 37%. So when the palliative treatment, we have the potential for further improvement of diagnostic. That's through the early diagnostic, even maybe from screening program, we can use it and we can reduce this palliative treatment. And here, local failure 80%. Here, of course, the improvement of therapy. So you have IGRT and other modalities, so we can improve this local control. So it's a very nice slide. I happy to show you that there is a still potential to improve the diagnostic and therapy in future. This is actually known to you, everybody. I have taken from the ICRO 50. You know, when there is a tumor, it is a classical 3D concept. So I will go to the 3D concept first. You see there is a possibility this tumor in this uniformity from plus 7% to minus 5%. This is actually, we should hold this concept, but sometimes in mama treatment, you cannot do that according to the how the woman's configuration. So the medical doctor decided, sometimes there is exception. He can take the values a little bit divided from division from here. And of course, this is a tolerance table. Everybody use this one. I will show the tolerance table. This is a challenge. Not only the 5 to 7% you hold, even here is the different value is given for the tolerance. Yeah, how you fix the tolerance of 5% risks or 50% risks in after 5 years, and when you should measure this one. And these are all the radiation consequences. So please hold this table while you do some plan. Here I have given you, I told you this is radiotherapy, and radiotherapy has a huge application in physics, mathematics, technology, biology, and everybody, you know, this curve, the probability of normal tissue, this MCTP and tumor TCP, and we should consider from every tumor how optimal we treat tumor without doing some harmful to the normal tissue. This is actually a decision what every medical physician is doing every day. And you see this this spherical conformation and time conformation and biological conformation. These three conformation we are doing that. And of course, when you have IMRT plan or a VMAT, they are automatically done by the computer. But you, the physicist, give the computer your demands. Here, everybody knows this one, the treatment planning, and this is spherical conformation. Here is the this is a multi-leaf collimator. I think it is a very, very interesting, the multiple parameter. It is earlier time we use them block, yeah, when it is a heavy work and takes time, but through the multiple MLC, we have very, very nice everything you can form, and you can conform in the spherical configuration. This is the idea from Andreas Brahme from Sweden. He gave a lectures, why not many leaves and why not many motor. Yeah, the simple idea, and the technique and the vendors, they have realized it. So the multi-leaf is now we cannot do today. We cannot think about without multi-leaf. In earlier time, left you see what at the time. Here is actually I have given a beam modeling. Everybody know how beam modeling with the help of the beam eye view. This is actually a very we are thankful to the computer technology that give us the chance. Yeah, I have done treatment planning with too many just in the dark. Now you can sit in the radiation direction and you can adjust your plan. This is a fantastic modality, be my view. And here every medical physicist should know we can do the type of radiation energy optimization. Yeah, we have the modalities here. We have modalities with photon beam and electron beam, and the physicists know the distribution of photon and electron. This is actually deep therapy, and this is the superficial therapy. Even we can combine for a certain cases. Earlier time we have combined every day, but now you have so many possibilities in photon ray. So most of you have forgotten there is another radiation, but in case you can do also this. Here in electron you see some scattering, and when you adjust the field, then you should know this is physics, and you should adjust both consequent fields. And of course the optimization entry point, this is still in radiotherapy MRT, you know, entry point is given. Yeah, how you give the entry point so that there is a good optimization. It is a use of beam modifier and compensator. And here is a number of beam numbers. Yeah, you can increase the beam numbers, and of course the weighting. Yeah, these are the play what medical physics is done in 3D process and learned their capability, and of course through this they can learn physics and technology very well. So here actually the different modifiers like wages, and that can be used. I give you, everybody knows this. And of course you see here 3D planning also possible. All the indications, it started from mama, bronchial therapy, posting, rectum, larynx, and metastasis, sarcoma, or lymphoma. You can use everywhere. So here I have already described my spherical configuration. Now you have conformation. I think conformation. Now is the time conformation. You see, with the time, some certain tumor is just changing its place, and through this is actually the IBRT is very important in this case. You see here localization and planning and treatment. This is the normal process. Yeah, what doing, and this is actually localization and treatment planning, the IGRT. Yes, you can, with the help of image modality, you can see how it's changing, and you can plan. And adaptive therapy, it is actually the last one we think. This is the localization, planning, and the treatment. Localization, planning, treatment. But many hospitals, they are doing not every day, but you can maybe in the beginning planning and treatment, and the middle of the session you can again planning and the treatment, and maybe 2/3 when the session is went, then you can again maybe 2 or 3 times you can use the planning and treatment. This is also we called adaptive therapy. And it is also possible, this is biological confirmation. Yeah, you see here different types of markers is possible when they give different sensitivity of the tumor, and so it is also the possible to escalation in this range where you need more dose. Yeah, it is it does not use it do not use very well, but some special cases the medical doctor also use this conformal biological confirmation. So I have taken here a dramatic technical change. You see here many things. You are the new generation, many of you, and you know what all our tools is possible, and these tools can be used properly. Yeah, and this is actually the future trends, and I will show some slides in my lectures, and you can see what is the, here you see here is the distribution of patient care. Here is the timeline. We do not know whether this curve like this or this curve like straight line. What is the development in future, we do not know. Yeah, the question is that the medical physicist on radiotherapy changing day by day. and we have a huge problem to overcome. So medical physicists are used. The question is, I have seen many developing countries, even in industrial countries, the number of physicists is very less. Yeah, so there should be a ordinance, there should be laws in this country according to the apparatus, according to the number of patients, how many medical physicists should be applied in the department. This should be a law. Yeah, I have seen many countries in the radiotherapy department, the proportion, yeah, the proportion of medical doctors or medical physicists is so high, you cannot imagine. They have 13 medical physicists, 14 medical doctors, but only two medical physicists. This is a very disparate situation. We should change it. And you, the medical physicists, show your flag. You know the laws, and laws in your side, and you understand, and you actually handle it. So here is actually we need medical physicists to be a leader, also a leader of this radiotherapy department. Yeah, he can change the situation. When you sit and you do not show your rights, nobody care for that. So you show your flag, and you know how many physicists need in the hospital. Yeah, and this is very. In our hospital, old hospital, we have the same number of medical physicists and medical doctors. Can you imagine? Yes, we had this one. Same number of medical physicists, same number of medical radiotherapy. So please think about that. Here actually IMRT, everybody of you knows this IMRT. Here I have given some points, more emphasis on statistic, prescribing and reporting with dose volume specification. Yes, this is a dose volume specification. You know what is this, and more modern therapy, not in ISO dose, it is the dose volume specification. Please make it clear. And here you see need to report medial dose 50% or other percent. The model-based dose calculation include the effects of tissue inhomogeneities, report dose to small masses of water, no dose to tissue. Those are the, you can find here this 83 ICRO report 83. I think it can be also download, and please here you can read the IMRT procedures very well. Here the IMRT I have given here example, the node spread cancer. Yeah, here's the purple. You can see.
Hello, sir. We can't hear you. You have mute yourself.
Yes, yeah. Oh, that's why there's a signal. Yes, now you can hear me. Yeah, you see with the MRT, how can you do a very perfect complex area, and of course the many residual organ, you should check it. It is possible through what I have given for you. Maybe is very important. Conformal 3D, you have a aligned with the target volume. But in IMRT, the ISO dose aligned to the shape of the tumor. That's why you have such types formed in tumor. Yeah. So you align to the ISO dose, and here align the shape of the target volume. This is the difference between classical conformal therapy 3D and intensity modulated therapy. Here, this is the runner. Yeah, this is actually the runner of VMAT. Without VMAT, we cannot live today. It is a rapid, it is a rotational IMRT. You see, there is advantage, short treatment time, very good dose conformity. Actually, in IMRT is better conformity, but here you need less MU and short time. I can say here you have less MU, short time, and you can do also better plan. So the VMAT is actually runner, and you can do with this VMAT all the indications. I have given you here some comparison between VMAT and helical tomography, and you can see this is the two indication of different dose. And here in this case, you can do VMAT is the same as helical tomography. So with your linear accelerator is enough such case to do the treatment planning. Of course, in helical tomography, these people invest more money, and they have special cases, especially when many indication they can with the same scanning they can treat the patient. So also there is a advantage, but actually most things you can do with helical tomography. What you can do with helical tomography, you can do also VMAT. Here I have given you a very interesting ART, yes, adaptive radiotherapy with this LINAC with the MRI. This is also some hospital in Germany and all other countries. You see, when you see here during the treatment, after some session, you can the tumor is smaller, which cannot be seen with the classical imaging modalities. But with the AMRT, you can see very well how the tumor is smaller, and so you can also adjust the field accordingly, which cannot be the classical, and that is actually important. But this is a very expensive, but it is also coming. Yeah, in medicine is never thought about expensive. They invest everything, and I think we should always think about the price. And you can hear the problem with medical physicists when you have MR, LINAC, that the dosimetry is also changing. Yes, because when the radiation from photon come to the body and produce the electron, and the electron is actually through the magnet field is changing. So the dosimetry is a new art from dosimetry. So when there is a machine good for the patient, it is complex for us. And therefore, we should have more medical physicists in a hospital to overcome such types of problems. And here I have given some 2 slides from vendor with the same plan. This is actually the Versa from the Electra, when they have the possibilities to have a many metastasis. Here is the 14 metastases in brain, and they can treat with the same time in the one session. Yeah, we go to one and the next and next, and so actually the problem is here. I also asked medical doctor, many of them told me, yeah, when you have some tumor, some metastasis more tiny, you can detect it. What is this with the things? So somebody is still doing some classical, they treat the whole brain with 2 or 3 fields. But we should accept the innovation, and innovation is always good, and the quality control is also needed such types of cases. This is the possibility. You can see here also SBRT. I do not, the SBRT is also very important. I think in the country like Pakistan or other countries, populated country, the SBRT is an option. Yes, it's less session. We can treat the same quality as in 30 or 40 session. When we reduce the session only 3 or 4, and we have a very good quality, and we can maintain the very good quality with the physicist, why not with 3 or 4 sessions? So we can treat more patient. So most of the developing country, we have used patient but less machine. Yeah, that's why with the same machine, when we use the SBRT, then this is a perfect solution. I think it should be done in future. And here you see the HyperArc. It is also from the Varian firma. They do also HyperArc, different arc in the brain tumor. Yeah, and it is actually used in the oligometastatic breast cancer and in the brain. Yeah, you see here 6 green, 5 fraction, and 6 minutes total mean time. So I have another 5 minutes. I should hold the time. A rapid plan, the knowledge based. Yeah, everything is knowledge based. You are the generation. Most of you are, I think, also young, And this is actually also future when you have big data problem and artificial intelligence. We use this big data and artificial intelligence, then we can take the experience of experienced people and use in our hospital. Yeah, radiometry, radiomics, you know, the another brands of radiology where you can also detect tumor better. Yeah, in radiomics. Yeah, this is also coming. So I think in the curricula of the new medical physics education, artificial intelligence and big data should be a part. I have the opportunity to do a curricula in European Union, and I was one of the author, and we have a very nice curricula is designed. If there is also a publication, if you want, please write me. I can also send you how we thought about the curricula, included curricula, artificial intelligence, and of course the big data in your education. I think this is coming more and more, and it should be also considered in the education of medical physicists. Last but not least, here you see the oncology care management. Yeah, this everything is actually everything is included in the process. So the pathology, radiology, radiotherapy, patient administration. So we can exchange our knowledge. We have the information, and everything can done in future. This is actually the magic of IT in future. It is also coming in oncology. So I have 3 minutes. So last of my slides is quality assurance in radiotherapy. I have given actually here some things, you know, everybody. Please also go to the internet and find, because some small country like Switzerland or Holland, yeah, not Holland, it is a Netherlands. Holland is part of Netherlands. So this country, they have also very nice protocol. For example, the quality control medical electrons, it is from Switzerland. And you see even the code of practice for the quality assurance and control of volumetric modulated arc therapy. So there is also a protocol, very nice, how you can design your quality control with VMAT. Yeah, this is fantastic. Big country like Germany, yeah, they have all in German language. It's not easy to find, but a small country, they are doing their research also in English language. Don't forget, go to internet and find some suitable quality protocol for you and apply based on your needs in your own country. This is my last question. Yes, it is actually given by me, the Asad Yusuf. I put it here. I think this is also my lectures. And last but not least, here I am also a fan for the VMAT because it is easy and everybody has this linear accelerator, and it is you see the more the question is more MU, short treatment time, or a less conformity. Yeah. Yes, very nice. You have learned a lot. Short treatment time, yeah. More MU is not, and less conformity is also. A conformity, you can say, maybe with the MRT is the same, but MRT is better conformity. Thank you for the answer of this question, and you have learned a lot, you know, very well. I wish you good luck, and I think we will discuss and we have a little bit time. So I am finishing 45 minutes. I hope you have enjoyed it. Thank you. Yeah.
Thank you, sir, for such an informative session. Everybody, I would like to remind you that attendance has been posted. Please mark your attendance, and if you have any questions or queries regarding the presentation or maybe any comments, please type in the chat box.
Yes, yeah. Can anybody moderate and tell me? Maybe I can answer some questions. Here is the border. Thank you, sir. Yeah. Kindly participate. Oh, good. Okay. What can I do?
If you have a question, you can unmute yourself and ask directly.
Yeah, please. Yeah, we can also open discussion. Yeah, you know, there is a German saying, there is no foolish question. We have only foolish answer sometimes. So you can ask any question.
So we have a question by Benish
Yes.
Ahmed, and it says, could you please briefly describe VMAT?
VMAT.
Yes, sir.
Yes, VMAT. Yeah, this is actually IMRT. Yeah, I told you is a volumetric modulated therapy. You know the IMRT. You know this how it's functioning. Yeah, through the movement of the MLC, you can modulate your radiation. Yeah, when the radiation come, earlier time we wanted always a flat beam, but this flat beam now is actually the philosophy changing through the different movement. It can be through the velocity. It's opened the, just a simple example. When you dynamic wages, how can you do the wages? There is a manual wages and the dynamic wages, hard wages and soft wages. Just you open the field and you just close and close, and when you see the beam profile, then you just like a waves beam, and it can be done according to your angle what you need. This the same is done actually for the IMRT cases, that you change this everything, and they have an inhomogeneous beam profile, and this can be used when you have a volume of PTV and resic organ. You give the constraints, and then the computer, according to your constraints, the computer asks the beam to modulate in small beamlets. It can incite some places more intensity, other places less dose, and so they all are doing the optimization. And after that, you have such types of dose distribution. Yeah, and this is the same. You see, then you have this step and shoot technology. So the tape and shoot technology, you can actually now, with the tape and shoot technology, you can actually move without any interval, and then added all the beamlets and all the information and all modifications, and you have actually the distribution what you like. Yeah, it's a mathematical dealing, and with the mathematical, we have this confirmation.
So we have another question, and this is from Saida Naima Fatma, and it says, so what technique was used earlier when CT wasn't employed?
Please, once again.
What technique was used before CT was employed?
Oh, what techniques was used earlier when CT wasn't employed? Yeah, I told in my lectures, just X-ray photos. Yeah, what is CT? You should at least two X-ray photos, at least two. When you have two, then you have a three-dimensional thinking. So I have one X-ray. Just you go to the medical doctors, yeah, for a chest examination. When there is a problem in medical doctor chest, he or she done two photos, one from the front to the back and another from the side. Please think about when you have two photos, you can see the three-dimensional. You can, at least you can understand which organ. When one photo, then all are lapping in one. When one photo, then all are lapping in one level. So you cannot distinguish the y-axis. Yeah, only. Therefore, you need another one, and you can judge the different organ lie in different places. The medical doctors can see this one. And when you have still two photos, it is a very fundamental. You can make more photos from other angle, maybe 5 photos. Then you can again see the three-dimensional better. You can make 10 photos. You can see better. So this is actually the photos. When you increases, it is CT. So that's the question is before CT with the simple X-ray photos are needed for the treatment planning. Yeah, that was. Even I have done this one with the medical doctors together. In the 17th, there is no computer tomography. Our hospital in Germany, in Heidelberg, we have our CT. It was 1983, I think, so the first CT. At the time, you can imagine we have no treatment plan, no CT. Yeah, we should treat the patient. Yeah, we have done. Yeah. I took sometimes 5 to 4 hours to construct 80% and 20% dose, isodose. And I give this in medical doctors. Here is the 80% dose, 3 slices, yeah, and we can draw it. Actually, you need that. That's why we have never tell you your knowledge in CT or MRI or linear accelerometer. It is just later the tools training. What you should learn, how to handle things with physics and technology and mathematics. This is, you are different from a technician or other people. You know your tools, physics, mathematics, and of course the technology. And when there is a problem, you think about, so is my situation, how can I do with my situation, the needs of medical doctors. You have now better tools, so it's easy to make, quicker to make, but the physics and the technology and mathematics, it gives always the possibility to do something, from the problem to solve. Yeah.
Good evening, Dr. Zakeria. It's Mansoor Naqvi.
Hey, hello. How are you?
I'm fine. How are you, Dr. Zakeria? It's
Yes,
pleasure
very
to see
nice.
you here and
Yeah.
participating in this event. And I think your talk would be incomplete if you brief the participants a little about the South Asian Cooperation and how you help medical physics trainees and students to get their small residencies in Germany and other countries. I request you to please brief about, because many junior students are here and they would be benefited from your thoughts. Thank you very much.
Thank you, Dr. Naqvi. It's nice to hear from you. Your voice, it cannot be, it cannot be. Your voice is always, I understand this is you. Very nice. You is one of the promoter of medical physics in South Asian. Our philosophies we have learned. I leave Germany as a 18 years boy. It is just after the independence of Bangladesh. You know, Bangladesh was at the time East Pakistan. I told always Mansoor Naqvi, my all certificate is also from Pakistan. I have not a single certificate from Bangladesh. I am the last batch of intermediate in East Pakistan. It is 1970. After the independence of Bangladesh, I received this scholarship in Germany. So my whole education in Germany, and I actually lived there. We are the generation who has at the time learned many things from life. So I have the opportunity to do something from the from our countries in Bangladesh, and of course I have done something for the countries. I have established a medical physics department there, and they are doing well, and the bachelor and master medical physics you can learn. And we talk with the German partner, because I am a long time. Yeah, I'm not a long time in Germany, so I have many friends and everybody working somewhere. So I asked them to extend this cooperation in South Asia, because the problem in South Asia are more or less same. So we extend our cooperation in the whole South of Asia. So these 8 countries, and I have tried to bring them medical physicists from other countries to Germany for short training, for seminar, PhD work. I have also selected one Pakistani student for PhD in Germany, but the corona is actually did not allow us to realize this one. So there are many. So the South Asian Center for Medical Physics and Cancer Research, please, I asked you do for yourself and for the South Asian country, because this 8 country has 40% Asian population and 1/4 of the world population. It's a small area. We have huge problem, but we have also huge possibilities. Can you understand when these all countries, Pakistan, India, Nepal, Sri Lanka, Bangladesh, when they work together, we have the same culture, we look like the same, yeah, when everything, we taste the same, we hear the same music, we are playing cricket. So there is so many similarities. We cannot do everything, but our small area, medical physics, you can do. So I think in a cooperation is always better than the efforts of their own country, yeah. And of course, everybody should do their own countries and all the potential they should use, but at the same time, a cooperation is needed. We are doing this. So again, in the Corona side, we have done many e-learning program. The next e-learning program started from 1st of July. If you have time and you can manage, please also take part, so you can encourage this initiative. And I hope in future we need people and active people to do our cooperation efforts. So long I can, we are also planning after the Corona, again, cooperation with Germany and South Asia. And I talk with my friends and colleagues in Pakistan, India, Sri Lanka, here, Professor Nagbi and others. How can we design the next cooperation? What is our need so that we can use this cooperation with Germany to develop medical physics in South Asia? It is not only therapy, diagnostic is a very nice, is a huge area. Yeah, you know, from 2019, 1st of January, I'm very happy that the CT and interventional radiology, we need physicists, now fixed. Yeah. Earlier time, I know one of the medical physicists doing diagnostic is Dr. Mansoor Nagvi, I know him. Yeah, he was also done many things in Germany, and he's actually diagnostic. And now we are medical physicists coming in diagnostic. Yeah, I have learned some Pakistan medical physicists in Dubai. No, in Doha, they have taken part in IMPCB, and I am one of the organizer of IMPCB. And there I have learned some pieces from Pakistan, and they are doing diagnostic very well. So your country is a huge, a big country. Pakistan is a big country, it's a very important country. And you have also the potential, you have a brain, and why not a very good medical physicist, medical physics in your country? I hope you will do very nice in future.